तुम्ही कसं काय तसं ते दिसतंय ना.
नमस्ते बेटे, क्या हाल है? आया तो नहीं डॉक्टर अभी? नमस्ते आंटी, कैसे हो? ठीक हो? चलो। और आए तो नहीं भी डॉक्टर साहब? आए तो नहीं? आएंगे अभी कि नहीं?
मैंने कर दिया था।
अच्छा 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 अच्छा। और कोई दिक्कत तो नहीं?
दिक्कत नहीं।
ठीक है ना? चलो, मैं कब पूछ के आऊं पहले आपसे। चलो, खाना खा लिया आपने?
Am I audible?
मॅम इथे फक्त एकच माईक ऑन ठेवता येईल.
माझं बंदच आहे.
तुझा स्पीकर ऑन आहे.
हा, स्पीकर असेल.
तुमचं म्यूट आहे पण स्पीकर ऑन आहे. त्याच्यामुळे
Please join all participants. The time is over. As per schedule, the time is 1:30 p.m. Am I audible? There is echo.
इथे फक्त एकच माईक ऑन ठेवता येईल.
माझं बंदच आहे.
Please mute all participants so that session could smoothly conduct. Please mute.
स्पीकर ऑन आहे. स्पीकर असेल. तुमचं म्यूट आहे पण स्पीकर ऑन आहे. त्याच्यामुळे
Please join all participants. The time is over. As per schedule, the time is 1:30 p.m. Am I audible? There is echo.
इथे फक्त एकच माईक ऑन ठेवता येईल.
Okay. Am I audible? No response. Am I audible? एक मिनिट इथं येतोय का आवाज? येतोय ना? Am I audible? Please join all participants. All participants are requested to join quickly. Our webinar will start in few minutes. Dr. Vipul Dikshit, are you here on online? Okay. Vipul Dikshit, please give response. Okay. Okay, ठीक है. Now we will start our session, that is webinar. Dean of MUHS Nashik, Administrative Officer of CSMSS Institute and Principal of CSMSS Ayurved College, respected Dr. Deshmukh sir joined this webinar. Thank you very much, sir. Our webinar observer, Dr. Vipul Dikshit sir also joined. Thank you and welcome to this webinar. First of all, I would like to give self-introduction. Myself, Dr. Patole Lalita Nivrutti, Associate Professor, Komarvritya Department, CSMSS Ayurved College, Aurangabad, and coordinator of this webinar. I heartily welcome all the participants who are now online as a webinar. And there are more than 900 registration, and now online participants are 264. Thank you very much for this huge response. In this webinar, there are 3 sessions. First session is of inauguration. Second session, guest lectures. There are 2 lectures. And third session is valedictory function. As per our tradition, we will start this session with Dhanvantari Stavan. I request all the participants to be silent for Dhanvantari Stavan. It will start in few minutes. So please keep silence. There is a photo share. Ni re ga re ma ga रे ग म प रे नी रे सा आ आ आ आ शंखं चक्रं जलोकां दधतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मं स्वच्छातिरुत्यं शुकपरिविलसनं मौलिमं भोजनेत्रम् कालाम्बोधोज्ज्वलाङ्गं कटितटविलसचारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगतवन प्रौढतावाग्निलीलम् वन्दे धन्वन्तरिं तम् ॐ शान्ति शांति शांति. Now I request our HOD Dr. Ratnaparki ma'am to speak few words. Over to Ratnaparki ma'am. Please come ma'am.
Good afternoon, everybody. Welcome you all for this webinar. Our Comorbidity department organized this webinar on the topic cerebral palsy. Within this academic year, this is our 4th webinar on cerebral palsy. Cerebral palsy is a common neurological disease which affects the child and the life of the child and also life of the parent also deteriorate by this disease. I think Ayurveda have a great scope in the management of CP. In today's webinar, our 2 eminent speakers are Pai Madam and Linda Madam. I welcome them all and MUHS appointed Dr. Vipul Dikshit as observer for this webinar. I welcome also him. And before started this webinar, I would like to call our principal, Dr. Deshmukh sir, to say a few words for us, to encourage us and to guide us. So please, Deshmukh sir. Over to Deshmukh sir.
Yeah, thank you. Thank you, madam. Am I audible?
Yes, sir.
Yeah.
You are audible.
Yeah, I would like to welcome first of all the participants here who have joined online, and also lot of people and lot of faculty members and students and PG students. They have joined through YouTube channel also. I would like to congratulate our department of Comorbidity Tantra for arranging this type of national webinar on cerebral palsy, and also the team of faculty members headed by Dr. Ratnaparki madam and her colleagues Dr. Patore, Dr. Gadkari, Dr. Fadnavis, Dr. Jatal and Dr. Durve, and also the academic in charge Dr. Jayashree Deshmukh madam, and all other faculty members of the institution and through participation. This national webinar is being sponsored and is permitted by the Maharashtra University of Health Sciences. I would like to thank to Dr. Pradeep Avade sir, who is the research officer in the university, who has taken efforts to grant permission from the university through the registrar sir and through our honorable vice chancellor madam. And from MHS side, we have observer, and I'm very happy to know that Dr. Vipul Dikshit from Bombay, he is the observer on behalf of MHS Nashik. We have two eminent speakers because the topic is very critical and very important in the society, and it affects the life of not only the patient but also the all family members. And the period of affection is very long, and the role of Ayurveda in that management of the cerebral palsy is very critical and very important. And the topic will be explained by Dr. Preetam Pai, who is the senior faculty member and also doctorate in Komar Bhrutya Tantra from the Bharati Vidyapit, Pune. And she has accepted our invitation, and she is with us now. I would like to thank and welcome her on behalf of our institution. And we have another faculty who is also senior faculty member, Dr. Snehal Rathi, Linde Madam. And she is also masters in physiotherapy, and she is the senior faculty member in Oyster Physiotherapy College, Aurangabad. And she will be focusing on management of the cerebral palsy through physiotherapy, and which is very important and very vital because the physiotherapy part is not being focused, and it is very important, and it plays very important role in the management. And this topic is everybody must know who is practicing this comorbidity or Balbrog or pediatrics. So I will not take much of your time. I would like to wish every success, and this will spread the message throughout the participant from Maharashtra, also outside of Maharashtra. So I would mention here my best wishes to this national webinar, and once again thank to university for giving permission to this webinar. Thank you very much. Thank you, madam.
Thank you very much, sir, for such motivational speech. You always motivate us. Now, and again, thank you for such a huge response from the participants. More than 900 registrations are there, and I am observing that online participants are 344, and just the webinar is starting. I think this figure will be increased. Hope so, probably. I am waiting for Pai madam. Her time is 2 p.m. to 3 p.m. Pai madam, are you here online? She is not joined yet. She had OPD work. She will join within few minutes. Meanwhile, request to all participants that feedback link will be posted only in chat box. It will be not sent or shared on your email ID or WhatsApp group. it will be posted only in chat box. Remember that thing, and you have to fill that feedback form, then submit that, and then you will get the certificate. So, and that feedback link will be posted during this webinar session on the chat box only. So be careful for that feedback link. Now the online participants are 352. Done. We madam also join this webinar. So we can start the second session. On the occasion of Azadi Ka Amrit Mahotsav, Department of Kaumarbritya arranged this webinar. In second session, first lecture will be conducted by Dr. Pritam Pai. Please mute.
हो नाही मला नेटवर्कचा लय प्रॉब्लेम.
Please mute. Okay. The topic is Principle of Management of Cerebral Palsy according to Ayurveda. Guest speaker is Dr. Pritam Pai. She is MD in Kaumarbritya, PGDCRRA, that is postgraduate diploma course in clinical research and regulatory affairs. Then PGPN, postgraduate course in pediatric nutrition. She is doing PhD, that is PhD scholar, currently working as associate professor in Kaumarbritya department, Bharati Vidyapith Ayurveda College, Pune. Teaching experience more than 15 years. Then in charge of Bala Panchakarma unit. Principal investigator of 2 research projects on cerebral palsy. One project is funded by Ministry of Ayush, that is Government of India. Second project funded by Bharati Vidyapith Pune. And her area of interest is neurological disorders in children. So over to Pai madam.
Hello. I'll share the screen.
You can share the PPT.
Ma'am, please allow me to share the screen.
Yeah.
Ma'am, please allow me to share the screen.
Yeah. Yes, you can share.
It is saying a host has disabled participant screen sharing.
You can share. You can share.
Make me the host. And
And the host
try once again. Yeah. Yes.
You are host now, ma'am.
Yeah, I'm doing it.
Yeah. Your PPT is visible, ma'am.
Yes.
Yeah. Slideshow is also there.
Good afternoon, everyone. Respected organizers of the webinar today, and my colleagues, dear colleagues, students. Good afternoon to everyone. The topic of my presentation is Principles of Management of Cerebral Palsy. Cerebral palsy, we know, is a neurodevelopmental condition. It affects muscle tone, movement, and motor skills. This is not a single disease. As I have mentioned earlier, it is a heterogeneous clinical syndrome itself, and mainly it results from injury to the developing brain. So this injury can be by a trauma, it can be because of birth asphyxia, or it can also be because of the various infections, which something like meningitis, meningoencephalitis, which I'll explain later. The current definition what we have for cerebral palsy is it describes a group of permanent disorders which leads to the affliction of movement and posture and hence causes activity limitation. And this is because of the non-progressive disturbances that occurred in the developing fetal or the infant brain. These motor disorders are often accompanied by disturbances of sensation, perception, cognition, communication, behavior, epilepsy, and by secondary musculoskeletal problems. So along with the motor problems which the child is suffering, that is a motor impairment, there are comorbidities such as epilepsy, impairment of cognition, vision and hearing impairment, disturbances of speech, and also of the gastrointestinal functions. So when we are dealing with cerebral palsy, a neurological disorder like cerebral palsy, in detail, we have to take the history, whether the patient is having epilepsy, like was there a history of seizure? What about the vision and the hearing? Has it been tested? If not, that has to be done. And regarding the disturbances of the gastrointestinal function also, the seizures, the gastrointestinal function, we commonly see that CP children have difficulty in swallowing. There is encopresis or there is constipation. So all this also has to be, we have to focus on these problems also, because you're not just concerned about the motor impairment. It is also treating all these conditions so that we can improve the quality of life and make the child more independent. It is a non-progressive but crippling disorder, and it causes a permanent damage to the developing brain. And because of this, there is physical and mental disability in the child. Due to this, the child is completely dependent on its parents for its day-to-day activities. And this is a big burden on the parents, one. The second thing is it is an economic burden or economical burden also on the parents. The child is, throughout its life, the child is dependent on the parents. So our aim is to teach the parents and also important make the child more independent. Prevalence of CP is 2 lives. This is a, and in India the prevalence is 2,000. Coming to the causes, as we know, we have the natal, natal causes. Coming to the causes, as we know, we have and cause is one which leads to age and also display. The infants are the who is encephalopathy less abnormal inherited malformations in the brain. It may other secondary to infants, and it can be because of the toxins like anti-epileptic I'll to not to some scripts. Please don't do that. It's PPTs. Palsy, stroke, natal intra and logical dysfunction such as anemia leads to chronic fluorescence into the chorioethatoid type of. It may be because coming to the post because causes and when have to take the birth the
Excuse me, ma'am. Ma'am, excuse me. Your voice is cracking, ma'am. Just wait.
Yes.
Your voice is cracking. There is some technical issue, I think. Just wait for 2 minutes.
Okay. Okay. Okay.
From your side, is there any problem, ma'am?
So it's not clear.
Your voice is not
just
clear, cracking.
Give me 2 minutes.
Okay.
Okay. Okay.
Slide is also not moving, and
no, I have not changed the slide. Is it audible now?
Audible. You are audible.
Is my wife voice audible now?
Yes, but something is there.
Okay.
Cracking sound is there. All participants are requested. Please mute. Please mute you, so that our session will be smoothly conducted. Please cooperate us.
Is it audible?
Yes, ma'am. Your voice is audible, but that is cracking noise.
Okay, I've switched off the fan.
Yeah, and
fan also.
Yeah.
Maybe if it was because of the fan. Okay, shall we continue?
Yeah, ma'am. We will see if there is cracking noise.
Yeah. Is it audible now?
Yeah, you are audible.
Yes, ma'am. Yes, you are.
Okay, so we'll continue with the. Okay, we'll continue with the slides. I request everyone to please mute yourself.
मी बोललेला
मॅडम स्लाइड एक वेळेस क्लोज करा परत शेअर
Yes, starting with the causes. So why should we know the causes? Why is it important?
Ma'am, excuse me. Stop this sharing.
Causes will tell us. Yeah.
Stop this sharing and again you rejoin.
Okay.
Again you rejoin.
Okay. Okay. Yeah, we'll do that.
Yes, madam.
So I should leave and join in.
Yeah.
I should leave the meeting and join again, you're saying?
Yes.
Okay.
Already our session start 5 minutes early. So don't worry.
So continuing with the causes, the prenatal, natal, and the postnatal causes. The why should we know the prenatal, natal, and the postnatal causes? Why is it important? So in detail, especially.
Mute everyone, please. Don't disturb. Mute everyone. Please.
Causes tell us about the area which is affected, the area of the brain which is affected, because each cause, for example, when it is a preterm baby, we know that there is a periventricular leukomalacia which can be diagnosed through the MRI. There is intraventricular hemorrhage. So depending upon the size of the intraventricular hemorrhage, it will tell us about the prognosis of the patient, how severe the condition it is, and how much of improvement we can give to the patient. Even in conditions like congenital structural abnormalities of the brain, because it leads to quadriplegic CP. And quadriplegic CP is more difficult to treat. We can, of course, provide some improvement, but when compared to the monoplegic or the spastic CP or the spastic diplegic or the spastic hemiplegic CP, quadriplegic CP is more difficult to treat because majority of the brain is affected. Or one more cause for quadriplegic CP being when the birth asphyxia is for a longer duration. And that becomes, it is one of the cause since it becomes difficult to treat. So therefore, causative factors are very important. The history relating to the causes should be taken in detail. Also, a hyperbilirubinemia leading to carnitis and hence leading to the CP, that is the chorioathetoid type of CP, where the pyramidal tract is affected. The postnatal cause also, the postnatal history has to be taken in detail. It will tell us about any infections which is present, how long the baby was admitted to the NICU or the PICU, and the follow-up of the sequelae helps us about the severity of the disease. Causes. So this is the study which was done at PGIMER Institute, Chandigarh in 2013, where they had studied around 1,200 patients, cerebral palsy patients who had visited their institute. And what they have studied, that birth asphyxia still remains the main cause, main etiological factor for cerebral palsy. This is followed by CNS infections, that is around 57%, and bilirubin encephalopathy is around 30%. Among the comorbidities also, what they found out that speech problem was very common in cerebral palsy patient, This was followed by microcephaly. Sorry. This was followed by microcephaly, seizures, intellectual disability. These are the other common comorbidities. See, even though the parents are always worried about the motor impairment and they always tell us that the child should achieve the motor milestones, attending these comorbidity is very important, because this, when we treat all this, we improve the quality of life of the child. There are speech problems, there are seizures. The presence of seizures itself, it retards the growth of the child. More of a brain damage occurs when the seizures continue. So treating the seizures is very important. And of course, the intellectual disability also should improve. So these are the other comorbidities which are present, and they have to be, we have to concentrate on these also along with the motor impairment. The common neuroimaging findings are hypoischemic changes and periventricular leukomalacia. So this we come to know through the MRI itself, and depending upon the area which is affected, how severe the periventricular leukomalacia is, all this helps us in our prognosis, because prognosis is very important. When the parents come, we need to tell them how long the child will require treatment, how much of an improvement the child will get from our treatment. Their expectations will be there, and hence all this has to be explained at the beginning. And that we can achieve by knowing, by taking a detailed history, by knowing the causes, the area of brain which is affected, the location of the injury itself, the extension of the injury, all this, and the comorbidities also. Types of CP, as we know, the spastic ataxic choriohepatoid, which comes under the dyskinetic type of CP, and the mixed CP. In the spastic CP, the spastic CP is the commonest of all the four, accounts for about 70% of the CP. So coming to the types of CP, there is the spastic diplegia is the more common one. Sorry. It is seen in 15 to 25% of the children. And the cause is periventricular leukomalacia, that is because of the preterm, prematurity. So initially, in less than 6 months of age, we see hypotonia is present. So hypotonia is not a type of CP. So it is only the initial stage. After 6 months, this hypotonia then gets converted to the spastic type of CP. And this is because of the neurological maturing which occurs. And that is why after 6 months, if we see commando crawl occurs because there is spasticity in the lower limbs. So if there is commando crawl, or if there is W sitting, the parents normally complain that the child is sitting in the W sitting, that is flexing the knees and then sitting, that is a W sitting. So they'll commonly complain that the child is sitting in this posture, and it is because of the spastic diplegic CP. There'll also be tendo-Achilles tightening. And another one is spastic hemiplegia, which is seen in 20 to 40% of the cases. The cause is either a neonatal stroke or prenatal stroke, cortical malformations. Here what we see is there is asymmetry while naturally using the hand movements. For example, because this is more prominent in the upper arms. So especially when the child is bringing the hands in the midline, for example, something like doing namaste or clapping. So you can see that the affected hand, the child will not bring to the midline. That shows that there is the affected, it will tell us which part is affected. That is, there is an asymmetry. And also when we are checking for the neonatal reflex like Moro's, so there will be asymmetry. So we know what Moro's is, how it is elicited, and what should be the normal response. So when that is not present, when there is asymmetry in the Moro's reflex, we should suspect one of the cause being spastic hemiplegia. Of course, there are other causes also. If there is a fracture of the humerus, fracture of the clavicle, then also there will be asymmetry, but this has to be ruled out. Then early hand dominance might be present even before 12 months. So when that is present, that is, the parents generally complain that the child is using only the left hand or only the right hand. The other hand, the child is not using at all. So that is dominance of the hand. And whenever the child is in sitting posture, the legs will tend to extend. This is seen in hemiplegia. The arms are more affected than legs. And when there is a sensory affliction, what happens is there will be a reduced bulk on the affected side. So that is why along I was mentioning about the history, then coming to the clinical examination, the examination of the higher mental functions, that is the cognition, the speech, the orientation of the child, all has to be assessed. That tells us about the higher mental function. Then the motor system examination, the sensory system examination has to be done in detail. Motor system examination, we have to examine the muscle tone, which is assessed, especially for spasticity, we assess it using the modified Ashworth scale. Then you have to assess the muscle power, muscle bulk, reflexes, and then the sensory examination also. So why should this be done? That tells us how much of improvement the child is getting every time. We have to follow up the child, and whatever treatment we are giving, we have to see how much of improvement is got in that child. So when, for example, if the child had a grade 3 muscle power, after 2 weeks or after 3 weeks, you're taking the assessment of the child, and now the child's muscle power is grade 4. You can explain to the parents, even they might not have seen this change. You might explain to the parents that there is an improvement and this treatment has to be done. What is the next treatment has to be followed. So all this will help us in counseling the parents, explaining them the treatment, helps us to assess the improvement of the treatment. Or if there was no improvement, it will tell us to change the treatment where we had went wrong. So that is very important to examine the patient, the motor system examination. Coming to the spastic quadriplegia, like I had mentioned, spastic quadriplegia occurs when there is some cerebral malformation when it is severe, cerebral dysgenesis, when there is perinatal asphyxia for a longer duration, congenital infections. So here there is severe motor and cognitive disability is present, poor head control. And here the child may have hypotonia for the initial up to 6 to 9 months also, and later that will be converted to the later that will be converted to the spasticity. And at 12 months, the child is unable to have a poor, the head holding will not be present. There will be a poor trunk balance. This tells us about the spastic quadriplegia. And under dyskinetic CP, we have either the chorioathetoid type of CP, and we have the dystonic CP, and we have the ataxic CP. Chorioathetoid type of CP is mainly because of the severe hyperbilirubinemia. When the hyperbilirubinemia raises beyond 20 milligrams per deciliter and was not treated by then it leads to kernicterus, leading to the chorioathetoid type of CP. So here chorea is present. There's an involuntary movement along with presence or absence of athetosis. Athetosis is especially seen when the child is reaching for an object. For example, there is an object and the child tries to grab it. The child will shoot against the object. That is the athetosis which is seen. There will be oropharyngeal difficulties also.
Madam, anything problem, ma'am?
Yes,
Internet
I'm
problem.
trying to change the slide.
Okay, okay.
Are you able to, 1 minute. I'm trying to change the slide.
Okay, okay. Again, there is cracking
Let me
sound.
do that. Yes. Can you see this slide, the dystonic CP?
No, spastic quadriplegia, dyskinetic CP.
Okay. Okay. Is the dystonic CP, is it visible, the slide?
No, no. Yeah. Dystonic CP,
Yeah.
ataxic CP.
So the dystonic, yeah. So under the dyskinetic type of CP, the previous one is the chorioethetoid type of CP, which I was mentioning. Then we have the other two, that is dystonic CP and the ataxic CP. The dystonic CP occurs mainly because of the perinatal asphyxia.
इतकं स्मूथली झालं होतं. Ma'am, you are disconnected, ma'am. Hello. Can you listen me, ma'am?
So is the PPT visible to all?
Now visible, ma'am.
Yeah. So the dystonic CP leads to repetitive twisting, posturing of the limbs. Sudden involuntary movements are seen affecting both the flexor and the extensor muscles whenever the child is attempting the movement. And tendon reflexes might we may not be able to elicit, or it might be difficult to elicit. And ataxic CP, the etiology is frequently not known, maybe because of the early prenatal events or genetic causes like cerebellar hypoplasia. They don't have a specific ataxic gait. So when we are examining the child, it is also important to know the child, what is the gait. Speech will be slow and interruptive and explosive. Coming to the management involves mainly in modern medicine, the management which is available today is the neurological rehabilitation, which mainly addresses the abnormal muscle tones. So through physical and occupational therapies. So by physical and the physiotherapy and occupational therapy, they treat or they manage the abnormal muscle tone. And occupational therapy also makes the child independent, so that the child can use or it will make the child independent on its day-to-day activities, like maybe going to the washroom or eating on its own. All that is by the occupational therapy. So there is only the therapy which is available. And diagnosis and management of comorbidities is important, like mentioned in the previous slide. Therefore, the management is multidisciplinary. It involves a treating physician who works with a team of rehabilitation, orthopedic, psychologic, and social care providers. So along with this management, when spasticity is present, it is treated with surgical procedures like tendon lengthening, tendon transfer, osteotomies, tenotomies, selective dorsal rhizotomy, which is also common. And there are botulinum toxin injections which are given at the muscles. These are short acting in nature. So the duration or the effective only for 6 months. Every 6 months, the child has to be injected again. There are baclofen intrathecal injections also orthotic devices such as ankle foot orthosis are present. So these are the newer advancements which are present for cerebral palsy. So as there is no cure available for cerebral palsy, the main aim is to maximize the functional capacity of the child and make him or her as independent as possible through a planned intervention program. So that is also our aim, to improve the functional capacity of the child and improve the quality of life, make the child independent. For this, we need a planned intervention program, which will also take in consideration the comorbidities. So an exact correlation to cerebral palsy is not available in our textbooks, but we can compare the clinical features of cerebral palsy to Vata Vyadhi, and hence the treatment of plan should be Vata Shamana, as Vata is the dominant dosha which is involved. So along with Vata Vyadhi, Fakka is also one of the diseases where we can correlate the cerebral palsy, because there is either delay or there is no achievement of the milestones. Causes of Vata Vyadhi, this reference is from Charak Samhita Chikitsa Sthan. So these are the various common causes which Acharya has mentioned. From this, he says one of them, that is, there is excessive movements like leaping, jumping, and physical exercise. So this probably might lead to the trauma to the child, leading to the brain injury, hence leading to CP. Sorry. Wasting of dhatus, like excessive loss of the dhatus, also leads to CP, such as there are bleeding, intracranial hemorrhage is present. That is one of the cause for CP. These are the general causes of Vata Vyadhi. Now, if we divide the causative factors as mentioned in Ayurveda, according to the antenatal, natal, and postnatal causes, under antenatal causes, there are garbhopaghātakara bhavas. So these are factors, that is aharas and viharas, which harm the fetus. So that can lead to either fetal anomalies or it can lead to preterm birth. So diets such as guru, katu, ushna, tikshna ahara, madakari dravya ati sevana by the mother. Regimen like ati advagamana, daruna cheshta, yana. There are many other causative factors which are mentioned under Garbhopaghātakara bhavas. I have mentioned only for you to get an idea. You can refer the textbooks. There are many more even explained in the Charak Samhita Sharidasthan. Under the natal causes, Akala Pravahana Janya Vyadhi. So when the pregnant lady bears down in absence of contractions, it leads to that. These are some of the features which are present, clinical manifestations which are present in cerebral palsy. So they can be considered as the cause. Prasava Kalina Vris also, maybe due to obstetric labor or due to forceps delivery, there can be trauma to the head of the baby. And this can lead to Ardita and Moha, Cheshtanasha, Moka, Gadgada. All are Vikriti in the Swara also. All are the clinical manifestations which are seen in cerebral palsy. So then the Pranavaha Sroto Dushti in the natal causes. We know that Pranavaha Srotas is responsible for Uchvasa, Nishvasa, all these. Also, it helps in the swallowing of the food. The Pranavaha Srotas is also located in the shiras. And when the shiras is affected, it leads to the affliction or the dushti or the abnormal functioning of the Jnanendriyas and the Karmendriyas. And we see in cerebral palsy patients that there is the abnormality of the or recession of the Chakshurendriya, Karnendriya. The Karmendriya is affected. The child is not able to walk. There is enuresis, encopresis, all are present. So that tells us about the Karmendriya also being affected. So we can compare cerebral palsy to various Vata Vyadhis. The spastic hemiplegia can be compared to Pakshaghata. According to Acharya Sushruta, he says there is loss of motor functions in one half of the body or one side of the body. The same manifestations are explained by Acharya Vagbhatta also. According to Acharya Charaka, he says there is loss of motor functions in one half of the body. There can be pain, there can be absence of speech. Ekanga Roga is when the affliction is one part of the body. He says that there is contraction of the hand and legs, pain in one half of the body. This can be correlated to the spastic monoplegia. Sarvanga Roga, that is to the spastic quadriplegia, when contraction of the hands and legs and pain in the whole body is seen. That is, the whole body is affected. Of course, we can compare CP to Fakka also. And under the postnatal causes, many of the clinical manifestations correlate to Skanda Graha. When a child is afflicted by the Graha, we see that there is Ekanayana Sravi, Shiro Vikshipati Muhur, Sabdangata, Sasveda Nata Kandara, Dantakadi Stanadvesha, Trestan Rodati Suram, Vakra Netrata, Vakra Vaktra, Vamana, Lala Strava, Urdu Nirshate, Vasa Asragandhi, Baddha Mushti, and Baddha Shakrat, Chalita Eka Akshi Gandabru, and Sarakta Ubaya Lochanaha. So these are some of the common manifestations which we see in spastic hemiplegia also, that also can be considered. So coming to the management, what I've explained here is Vata Vyadhi, because CP in general, we can correlate it to Vata Vyadhi. Once it can be either Pakshagata, it can be Sarvanga Roga or Ekanga Roga, depending upon the type of CP. So we have to see the condition first, whether it is Dhatukshaya or it is Avarana Janya, because the treatment protocol will vary accordingly. So if it is not Kevala Vata, he sees that Nirupastambho, Kevala Nirupastambho, Ado Snehai Upacharit. That is, if it is only Kevala Vata Vyadhi, that is, there is no Avarana, we have to treat it with Snehana, Bahya Abhyantara Snehana. So if there is Avarana present, then, for example, if it is a Kafavrata Vata Vata Lakshanas are Shaitya, Gaurava, Shula, and the child will have, or the person will have Ruksha Ushna Kamita, there will be Upashaya with Katu Adi drugs. The patient will benefit from Langana and Ayasa. So Kafavrata Lakshanas according to Acharya Sushruta are Shaitya, Gaurava, Suchi Bihinistuda, Sparsha Dvesha, and Prasuptata. So these signs are similar to the spastic CP. And he says that under the treatment, Ushna, Ruksha, Tikshna, Dravyas. So we can select a procedure which is Ruksha in nature using drugs which are Ushna and Tikshna. For example, when we are using Udvartana, it subsides the Kapha dosha, also causes vilayana of the Medo Dhatu, and it improves blood circulation, muscle tone, and mobility in the joints. So Udvartana we can do using drugs which are Ushna and Tikshna. Something like Kulatta Churna, Kola Kulatadi Churna can be used if it is Kafavrata. Then, once we are satisfied that the Kafavarana has been treated well, that has been managed, and it is then he says the sign of procedure is the Ba and Abhyantara Snehana. So even if we have to give Abhyantara Sneha Pana, which I will explain the drugs in the next slides, if you're giving Abhyantara Sneha Pana in the form of the Shamana Aushadhi itself, then first we need to assess the Agni. So how is the Agni of the child? Is the Agni good? Only then we can start with the Snehana. If the Agni is Manda or Madhyama, you can always give medicines to cause the, like the Deepaka Aushadhis can be given. Then we give the Snehana. For Bahya Snehana, we have Abhyanga and we have Sarvankara like procedures. And this is followed by Smeda. That is, yeah.
Your voice is
Yes.
Sometimes internet problem is there. Sometimes cracking.
No, my connectivity is strong.
Sometimes smoothly, sometimes cracking. You are rejoining, madam? Hello? नाही मॅडम आहेत. आता आवाज आला तुमचा. प्रीती पै, कृती पै, कृती.
Continue. Sorry for the disturbance. So continuing with the go to the previous slide. Yes. So coming to the Bahini achieved by Vyanga is one of the procedures. Then there is Sarvanga Dhara also. Vyanga is application of the oil to the body for massage. This is done in the direction of the hair. So for this we have divided Dhanara Taila, Bala Taila, Bala Ashgandhade Taila, Mahamasha Taila, Shilapala Taila, Mahasendva Taila also. It depends upon the avastha of the patient. Abhyanga specifies Vata and produces softness of the body, Mardavata, nourishes skin by its Mrudu, Snigdha, Guru, Pichila Guna. It helps in the promotion and regulation of the proper functioning of the Vata. The Snehana also can be achieved by Sarvanga Dhara. That is, Sarvanga Dhara we can do by using different oils, the same oils which was used for Abhyanga. It can also, I hope I'm audible. It can also be done using various kathas like the Shumul katha. Then the next stage is the Vedana. For Vedana, we can use the Shastrika Shalipinda Sveda Sarvanga Dhara. Sorry, let me finish with the previous slide. Then I will show this slide. Yes, let me finish this slide first. After Sarvanga Dhara, the Shastrika Shalipinda Sveda, which gives both Snehana Svedana, it is also Brahmana in nature, especially when there is Mamsa Shosha. This procedure is very beneficial. After this, Acharya says that either Mrudu Virechana or Basti should be given. So Niruha Basti or Matra Basti can be given, but we should always remember the bala of the patient when we are giving the Basti. And then, of course, Pratimarsha Nasya, under the Nasya, I would advise Pratimarsha Nasya, maybe using Shira Bala Tela or Anu Tela, depending upon the avastha of the patient. And Nasya is generally kept at last. It causes some discomfort to the child. So in children, as we know, whatever causes discomfort, we finish it off the earliest as early as possible with a lesser duration, or we have to keep it at the last when the child is more comfortable. So Nasya, I would advise at the last. Under the Abhyantara Snehapana and the oral medicines, there are very good drugs like Kalyanaka Grata, Mahakalyanaka Grata, and there are other churnas like Kalyanaka Avaleha Churna for the speech problems. Then we have Rajanyadi Churna, which is Deepaka, Pachaka, and is also useful in a disease like cerebral palsy. Before starting the Snehapana or the Sneha itself, assess the Agni. For you can give something like Hingvashtaka Churna to improve the Agni of that child. And then you can start with the Gratas, the medicines, which are Medhya in nature. And assess the patient every 15 days. So this will give you an idea how much the child is improving. And maybe every 2 or 3 weeks, you need to assess the patient. And it will also tell us probably whether we have assessed the doshas correctly or not, whether the dhatu avastha, whether it is being assessed correctly or not. Because directly starting Snehana without assessing the Agni will lead to more accumulation of the ama in the patient. This will not treat the condition as such. It will not cure the symptoms, and it might aggravate the condition also. That is why it is important to think about the Agni, the Koshtagni and the Dhatu Agni, both. And hence it has to be given. Even while advising maybe Mrudu Virechana, Niruha Bastis, Matra Bastis, we have to assess the bala of the patient. Even though Acharya has said that at 1 year of age, Niruha Basti can be given. But if the development is not up to the mark, for example, in a CP child, even at 1 year of age, probably the developmental age is only of a 3-month-old, then I would advise don't give Niruha Basti because it will cause some complication in that child. Matra Basti is more beneficial because it doesn't cause complication as such. And along with that, it causes Pakwashiya being the son of the Vata dosha. It treats the condition very well. And it also helps in the improvement of the, reduces the vitiation of the Karmendriya also. So this is a patient. I'll play the video first. So she has, yes, I'll explain. This child is having spasticity of the Achilles tendon. You can see when she's walking. She's a 3-year-old child. I'll play it again. Yes. So I advised her Udvartana, and after, along with oral medications also, Kalyana Grutta was given. After 20 days, this is 1 minute. Yes. So this is after 20 days. See how she is walking. So the spasticity at the ankle spasticity, that is at the Achilles tendon, is reduced a lot, and she is walking very freely. The spasticity is reduced just by 20 days of treatment. So this child is 1 year, when she was 1 year, 13 months of age, she came to me. She was not able to sit. She didn't have complete head holding. The head holding was only grade 3. And after 2 months of oral medicines, and she was, after 2 months of oral medicines only, they were not ready for Panchakarma procedures. They were not affordable. So when only oral medicines and Shiropichu was done, she was able to sit freely on her own, and her head holding was also complete. And then she came for Panchakarma procedure also. After 3 weeks of Panchakarma procedure, she is able to stand with support. So the support is given. She is able to stand with support. So this is one more patient. She is 2 years of age. So when she came, she was able to walk only with support, and she was not able to place the feet properly on the ground. Ankle spasticity also was present. The lower limb spasticity was present. Now, after 3 weeks of treatment, you can see that she is able to stand even with the mild support. Of course, her mother is holding both her hands, but she's able to stand even with support of one hand, and that is a good achievement. The next step would be she'll be able to stand without support, and hence the walking also without support. Yes. With this, I'm ending my presentation today. I would like to thank Principal Sir, Dr. Deshmukh, and Dr. Patole Ma'am, Associate Professor, Department of Kaumar Vritya, for giving me an opportunity to to give a guest lecture today on cerebral palsy. I open the session now for asking questions. If you have questions, you can ask in the chat box. I'll be happy to answer them.
Thank you very much, ma'am, for such nice session. If anyone has questions, you can put in chat box. Put your questions in chat box, please. Any question, please?
So,
Put.
ma'am, there are questions in the chat box. If you can read it to me one by one, I will answer them.
If child is 10-year-old and his symptoms started appearing after 9-year age, what to suggest his parents because he is having epileptic attacks recurrently? Child 10-year-old.
Okay. I would always ask, tell the doctors and the students, take a detailed history. So if the child is having epilepsy, and rule out whether there was a delay in the milestones from the beginning. It will never be that the child, of course, the parents might say that everything was normal, but ask for a detailed history, check the investigations, and then see whether how were the milestones, how was it achieved, so whether it was normal or not. So if it was slightly delayed also, it will tell us that the reason, what was the cause, and then it has to be treated. Epilepsy also, when recurrent epilepsy also will lead to the abnormality, it will lead to motor impairment. So that also needs to be addressed.
Second question is, tell the benefits of virechan in case of cerebral palsy.
Yes.
Virechan.
Yes, Mridu Rechan has been advised by Acharya also. And and then he also says that instead of Mridu Virechan, if you see the Charak Chikitsa Sthan, he says that, of course, the first line is Mridu Virechan. Then he says, instead of Mridu Virechan, you can also give Niruha Basti. So I generally advise either Niruha Basti or Matra Basti, depending upon the bala of the patient. If you want to give Mridu Virechan, you can give something like Kavipatikara Churna can be given. It is important that the child should take the medicine also. In children, the palatability is also an issue. So if the child is ready to take, then you can give Mridu Virechan. That is not a problem.
Okay, next.
For the impairment of the Karmendriya, what I've seen, the Basti is beneficial, better. Well, I've always seen that.
Okay. Can I take next question?
Yes, ma'am.
Which Svedan can be used in spastic CP?
Spastic CP, if after Snehan, if you want to give Svedan, you can give it, since it is a child, you can give it in the form of Nadi Swed. Or we combine therapies such as Sarvanga Dhara using oils such as Sahacharadi Tela, Basaranyadi Tela. So this gives both Snehana and Svedana to the child. That is more than enough. I would never suggest go for rigorous treatment. We need to give time because for condition like CP, it's a neurological condition. It will take at least 1.5 years for the child to be almost independent. And that much of time we need to give, with the continuing the treatment. Leukomalacia can be treated. There's one more question by Ayurveda. Yes, it can be treated. And it can be treated. 1 minute. It is a metabolic disorder, so the line of management is completely different. For Niruha Basti, what drug has to be given? Niruha Basti, you can give Dvipanchamuladi Niruha Basti, which is explained in Astanga Hridaya, Vatavyadi Adhyaya, or you can also give the Shamula Niruha Basti. Which Rasakalpa we can use in patients with CP? Rasakalpa as such, I'm not advising at present. I have used the herbal formulations itself, and I have found good results, such as which I had mentioned in the slide, like Kalyanaka Grata, Mahakalyanaka, Panchagavya Grata. Which Deepana Pachana drug to be used? We can use Rajanyadi Churna. It is Deepaka and Pachaka, and it is useful in cerebral palsy. Internal medicine, I have already shared. Kalyanaka Grata, Mahakalyanaka Grata, Panchagavya Grata can be given. Which cases there will be speech problems? In all cases of cerebral palsy, there are speech problems associated, and hence that has to be treated. And if possible, advise, they can go to a speech therapist also, and you can advise speech therapy. Because even in cerebral palsy, now I'm doing a research project also under the Ministry of Ayush, wherein one group I'm advising our trial drug, which is a media drug, and physiotherapy. And in the control group, it is only physiotherapy. So I have seen that there is good improvement in the motor milestones, and the values, the statistical value is significant in both the groups, but it is more significant in the trial group. Shows that our physiotherapy combined are very effective in achieving the milestones. Matra Basti, like all the Panchakarma procedures, it is given for 7 days. That is the procedure which I follow. So Matra Basti also can be is given for 7 days, depending upon the age of the child. For example, if it is a 1-year-old child, you can give 10 ml daily safely, and you can give simple oil like Dhanvantara Taila, and for 7 days. And slightly older children, like 3-year-old child, 3 to 5 years, you can give 15 ml of Matra Basti. For Nasya, you can use Kshirabala Taila. And if the child can tolerate, if there is Bahudosha Avastha, you can also give Anu Taila. Shirodhara, you can give Dhanvantara Taila.
Next question. Should we do Krumigna Chikitsa? Should we give Krumigna Chikitsa?
No, not essential. If not essential, if we see signs of Krumi, then it has to be given. Otherwise, not essential. Because anyways, we are advising so many medicines, it is better to omit as many medicines as possible. CP is diagnosed by what parameters? So there are specific signs and symptoms of CP. On the basis of that itself, it is diagnosed. There are no investigations as such which will diagnose the CP. Based on the clinical manifestations and signs, we diagnose the CP. Of course, if you want to know the cause, that can be known through the MRI investigations.
Quantity of Niruha Basti.
Quantity of Niruha Basti is according to what Acharya has mentioned. But if, like I had said before, even for 1 year, what Acharya has mentioned, you needn't advise directly. For example, the child is 5 years of age, but the development is only of 1 year. Then give the quantity as Acharya has mentioned of a 1-year-old child. You have to assess the developmental age and then give the dose of Niruha Basti.
Okay. Now there is time to conclude the first session. All participants, if you are some questions, I will put the email ID of madam. You can ask directly through email.
Yes, sure, definitely.
Okay. Thank you very much for your valuable and informative session, ma'am. This will be definitely beneficial to our students and participants also. Again, thank you very much.
Thank you. I'm happy that it was useful to everyone. Thank you so much for inviting me.
From practical aspect also, it is.
Thank you. Thank you so much.
Okay. Welcome, Snehal ma'am. Before that, one request to all participants. There will be feedback form link in chat box only. You have to fill that and submit also. Then and then only you will get e-certificate with MUHS logo and name. Link will be not available on email or WhatsApp group. Remember that it will be available only on chat box. Okay. Now over to our second guest lecture. Topic is role of physiotherapy in the management of cerebral palsy. Guest speaker is Dr. Snehal Rathi Lende. BPTH, that is Bachelor of Physiotherapy, and MPT, Master of Physiotherapy. Specialized in neurological pediatric science. Certified aqua therapist by International Holistic Association of Swimming Therapy, UK. Clinical experience more than 12 years. Presently working as Assistant Professor, Oyster Physiotherapy College, Aurangabad. Consulting physiotherapist at Shri Physiotherapy, Aurangabad. So welcome, ma'am.
Thank you, ma'am. Am I audible?
Yeah, you are audible, ma'am.
Okay, thank you so much, ma'am. First of all, I would like to thank CSMS College for giving me the opportunity to speak on and to make aware about the role of physiotherapy in CP. Is my screen visible properly?
Just wait.
Yes.
Now, your PPT is visible.
Yeah, is it visible now, ma'am?
Yes, there is slideshow.
Okay, thank you so much, ma'am.
Okay.
So, in detail, Pai ma'am has talked a lot about the causes of CP, how is it happening, what is CP, and in detail, it was a nice introduction given by Pai ma'am. So I'll not be going in that much detail regarding what are the causes, but as she had already talked about it, okay, so 3.8% of the global population is having disability at present, out of which 15 to 20% of this population is having CP. And as Pai Martin has already quoted, 2.9 per 1,000 births is affected by CP in India. So it's approximately around 3 kids per 1,000 births is affected by CP. And most prevalent form of CP is seen in preterm babies. Okay, so as all of us know that CP is also known as Little's disease, and CP is an umbrella term which encounters many problems. The most important and the foremost is the disorder of movement and posture, not allowing the baby to move from one position to another. And as already quoted, it is a lesion to an immature brain. Okay, so because of this lesion, there is disorder of movement and posture. And because of this disorder, the baby is having difficulty to carry on his day-to-day activities. And the foremost thing that we are all supposed to know that it is not genetic, it is not progressive, and it is not a hereditary disorder. It is just a lesion to an immature brain. Okay. So as already quoted, there are different types of CP. So one, by the physiological means, the classification that was being done is spastic, dyskinetic, and ataxic CP. Another type of classification is done by topographical classification, which is by the distribution. So it is monoplegia, hemiplegia, paraplegia, quadriplegia, diplegia. And then functional scales are also being used for the classification of CP, commonly in most of the doctors, that is GMFTS, that is Gross Motor Functional Classification Scale, which is used for CP. Here we can see the classification of CP by GMFTS, which is also useful for deciding the treatment plan when we are treating the patient. So here you can see at the level 1, the baby is able to carry out most of the activities independently without any help. In level 2, the speed is slow, but he is able to carry on his activity independently. In 3, he is needing assistance. In 4, the assistance is more. And in 5th, the baby is dependent on someone to help him to move. Okay, and the baby is having difficulty to do the movement also. Okay, so before knowing what are the problems encountered with CP, first of all, we should know that since it is a lesion to an immature brain, the brain is not developed as yet, and the baby has not learned the movement also. So, being a physio, we are there to help the baby learn a movement pattern. Okay. So before making the baby learn a movement pattern, we are first supposed to know what is the problem that is being encountered with these kids. So as most of us have seen CP kids, you can see here also, the baby is having difficulty to move the limb. He is being fixed in a particular attitude. The attitudes of the limb are fixed in flexion. It is commonly seen that the limbs are spastic. If we consider spastic CP, the limbs are spastic, but the trunk is hypotonic. Okay, there is no dissociation of movement. Dissociation of movement means the limbs are not free from the trunk to do a movement. On top of it, a group of muscles is spastic. Okay, not allowing the baby to move freely. Okay, so because some muscles are spastic and the opposite group of muscles is loosened up, the baby's movement patterns are not that of a normal child. So these are called as awkward movement patterns. And in some patients where there is asymmetry, for example, if there is a hemiplegic patient, there is asymmetry of the limbs, there is limb length discrepancies also which can be seen because of not proper weight bearing. Less weight bearing, less bone growth, giving you an asymmetric posture, later on increasing the problems in the spine also. Okay, so here in this picture you can see that the baby is having difficulty to turn also, difficulty to crawl, not allowing the movements to be encountered properly and freely. Here you can see because of persistent primitive reflexes, the baby is having difficulty to turn also. Okay, so here because of these primitive reflexes, the baby's overall motor milestones are also being delayed. Okay, these are the varieties of postures that are being adopted by the kids in the initial stages. Asymmetric posturing, extensor posturing, not allowing the flexors muscle to move. Okay, then that's why the essence of physiotherapy treatment in pediatrics is mainly about handling, how we handle the patient, allowing some group of muscles to activate, to strengthen, to mobilize, and helping them to come to a near normal movement pattern. Okay. So here you can also see that the baby is floppy, not able to erect himself properly. The common unwanted positions that the baby is adopting is W sitting. Okay, giving more more privilege to adductors, internal rotators, and hamstring to go into a tightness. So then we are coming in picture to train also how to perform the movement. Okay. So the decision on how to start on with the treatment and how to progress on with the treatment is being decided by the age of the baby, at what age the baby has developed which milestones, and considering and taking into picture what are the modifiable and non-modifiable factors which can be handled by a physiotherapist. Now, we have already been known that CP cannot be treated by only one profession. It's a holistic approach. All of the community which is treating patients, everyone is involved for treating that baby. Okay. So being a physio, our main picture comes to treat tonal abnormalities. If there is weakness in coordinated movement patterns, tightness, contractures, stiff movements, these are being treated by a physiotherapist. So being a physiotherapist, it's like we are physical therapists. Okay. We are made to make the people move. That's why we are called as physios. Okay. So as I have already told, lot of people are getting involved for the treatment. So medical is already there. Okay. From the rehabilitation perspective also, many people are involved for the development and upliftment of a CP kit. Also, there are special schemes given by the government also, like Niramaya scheme, which is helping with the financial burden that is being taken up by a kid. And after that, there is surgical management. In the initial stages, if it is not working, they think about Botox injection along with physiotherapy. And in the later stages, they do think about tenotomies, bone lengthening surgeries, or osteotomies. So it all depends on how the baby is being assessed. Assessment is a very important part when we consider treatment of a CP kit. At different levels, we see different developments. The baby can regrade also. Okay, so that's why continuous evaluation is required whenever we are treating a CP kit. Nowadays, it has become easy from the evaluation perspective. Anytime you can take a video of the patient, keep it in your data recording system with proper permissions taken from the parents and the relatives, and helping it out. Okay. So initial basic physiotherapy management of CP has already been known by most of the people. That is basic stretching exercises if the muscles are tight, strengthening exercises if the muscles are loosened up, muscle activation exercises where a muscle which is not able to activate, those activation exercises we are doing. If the baby is at the lag for getting the balance in sitting, standing, or supine position, that is being trained by physios. Tonal abnormalities are done or managed by proper techniques which are being taught, like Bruce approach, which is being used for managing it. If it is spastic, then we use the technique which is helping to reduce the tone. And then if it is hypotonic or ataxic, we use the technique which is enhancing it. On the most important part is encouraging a dissociated patterns into their day-to-day life. Okay, so this gives them a bit of a confidence to move around freely while performing an activity. Okay, but before coming to this, from ICU level or neonatal level itself, a physiotherapist is involved for the treatment of CP kits. Okay, so if there are babies who are in ICU, or if we know that the baby is at a high risk and is maybe having some neurological insult during or around the birthing process or after the birthing process, those babies are to be managed properly in ICU itself. So we are starting from an ICU for the treatment of babies. Okay, so in the initial stages, when the baby is in a fixed attitude or in a fixed position, they learn that movement. Okay, so as to avoid that, from ICU itself, we give various positions so as to inhibit the abnormal tone in muscles and facilitate tone in the muscles which are low at it. On top of it, we do give vestibular stimulations also, so that the baby retains the memory of a normal movement pattern. Also in NICUs, we do train the mothers and fathers for KMC, that is kangaroo mother care. Very useful technique in which the baby is being taken without any clothes, just a diaper, on the bare chest of the mother or a father. Why so? Because the breathing, the smell, the heartbeat of the mother is very much acquainted to the baby. And the smell of the mother is also acquainted to the baby. So he is in a known environment. He calms down, helping with a faster recovery also. On top of it, if the baby is having any secretions or any aspirations, so bronchial hygiene is maintained by chest physiotherapist. Then prevention of complications. If the baby is at a high risk and he is supposed to be having spasticity, from the initial stage itself, range of motion exercises, stretching exercises are to be inculcated so as to avoid any contractures later on. And the most important thing is to educate the parents from the start itself that how the further plan is to be decided. Okay, so after this, we'll be starting with what all treatments we are giving rather than this basic treatment. So functional activities, what as a physio we are mainly doing is encouraging functional activity as much as possible. So we are using different therapy balls on which the baby is taken so that the muscles are being activated properly. So here in the picture itself, you can see that the weight bearing is enhanced on the upper limb. Okay, so when the weight bearing is enhanced on the upper limb, there is a proper growth of both the limbs. There is no asymmetry which is there. And from here, we are teaching the baby to crawl also. So this crawling is helping with the development, attainment of the milestone also, which later on is helping the baby also. So there is finger opening with proper weight bearing. There is enhanced in the bone mineral density also. Otherwise, most of the time it is seen if the limb is not being used, osteoporosis set in early. Okay, so weakening the bone and later on causing fractures, and fracture again increasing the pain and spasticity for the baby, again limiting. So it's like a vicious cycle. So we have to break the cycle by giving proper weight bearing exercises so that the baby is able to explore the environment and carry on the activities properly. In other photos, you can see that gym ball is being used to enhance the strength of the back muscles also. So if a hypotonic baby is there, or dyskinetic baby is there, or dystonic, here you can take the baby on the ball, encouraging them to activate their extensors and do on the activity. Balance training is also being given on gym ball exercises. Okay. Other than gym ball exercises, we also take the babies, giving them various functional positions so as to incorporate and help the muscles to get activated. Gym ball is also being used to increase the truncal control and help the baby to get a balanced reaction later. Most of the time, if you tell the patient, do your biceps, do your triceps, the baby is bored. So instead of that, what we are doing is we are taking a playful environment in which the baby is able to carry on the activities and in a fun way. So instead of telling them to do biceps and triceps, what we are giving them ball and we are like, throw it. So throwing is an activity. Now always remember this, that the brain doesn't register individual muscle activity. What brain registers is a movement. So when the baby is throwing the ball, he's directly causing contractions of your triceps, encouraging the muscles to do the movement. On top of it, reach out activities by proper weight bearing on the upper limb also helps with the development of your scapular muscles. Playful activities, when incorporated, baby is also keen to come to you and do the exercises fatafat. Okay, in a happy mode. Now, most of the time, the most important concept of physiotherapist, pediatric physiotherapist is the handling technique. Okay, the way you handle the baby, it either enhances some movement, it should reduce unwanted movement. So here you can see in this picture where a therapist is properly holding on to the baby, facilitating the movement of the trunk by just turning onto the pelvis, encouraging weight bearing on the upper hand, and helping the baby to come to sitting position. So these transition between the movements are being taught by physiotherapists. Baby is, we are making the baby learn the new movement pattern. Okay, the baby will be doing the movement, but it will not be a normal movement pattern, and later on it increases the spasticity in particular group of muscles. So to break that, we are supposed to give proper technique. We are making the baby learn how to do that movement. Repeated movement help the baby to develop a program of how to come to a sitting position without causing any other or unwanted movement. Okay, so here we can see from prone lying position, the baby is being encouraged to come to sitting position by proper handling at the pelvis and at the trunk level. Same way, from the opposite side also, the baby is encouraged by using a toy and coming into a sitting position and doing the movements and playing. So baby is just engrossed in the playing, and the therapist is doing the necessary adjustment by handling the baby properly. Okay. Balance training, the most important component to stand erect and walk. What is being required is proper activation of the muscles. On top of it, balanced reactions also. So we are using different balance boards on which we are making the baby sit, stand in different positions so that particular group of muscles can get activated. And when the baby is actually walking, there is a carryover effect from balance board to standing. So when the baby is walking, he is walking with proper control. If he's not walking earlier. So this is not the if you are giving it treatment today, immediately we'll be getting the results tomorrow. It's not like that. CP takes time. Okay, treatment of the CP and getting the results takes a lot of time. The baby is supposed to do the exercise n number of times. We cannot specify it. This has to be done only 10 times or 20 times. No, 24-hour management is required with the baby. So the baby is there with us just for an hour or so, and during that time we are treating the baby. But take home message bhi dena padta hai. We train the kids. We train the parents and the caregivers what all things they are supposed to do when the baby is taken at home. What instruments are to be used, how they are to be placed, what all supportive devices are to be used when we are treating a baby. Okay, so here you can see to develop reactions in sitting, balance or protective reaction in sitting, we are using a bolster. Bolster is something like a load. Okay, it is cylindrical in posture. We are sitting on it with the baby and we are tilting it, allowing the lateral flexor muscles to activate properly. And when the muscles are being activated, the baby is developing the balance reaction in sitting position. Okay, same way, if we want to activate in forward, the balance reactions in the balance reaction in forward position, we are taking the baby prone on ball, and depending on that, the reactions are being activated. Okay, so it takes time, but the results are seen. Okay, weight bearing exercises are to be incorporated because if it is commonly being told you use it or you lose it. So if you are not taking any weight on your hand, okay, there will be shrinking of the hand, or what you can properly say is if you're not taking weight on the hand, shrinking is not there, but lengthening will not be there. So if you're taking proper weight on the hand, the growth of the bone will be normal, the muscles will be stretched, and the finger opening can be seen. So this is one form of exercise that we are using where the baby is taken in prone position and weight bearing is taken on the hand. So a lot of things are encouraged over here where opening of fingers can be done, elbow is going into extension, and on top of it, the scapular or the truncal muscles are getting activated when doing the movement. So after coming to sitting, we are training the baby to come to standing position. So standing position ke liye bhi handling is very important. So the most prominent, or what you can say, the center of gravity, the center of line of gravity is at the center in the pelvic region. So here we are holding on to the pelvis and guiding the movement. Okay. So the baby is learned and is made to shift the weight to one side of the body and then come to the standing position. repetition helps with the learning of movement. Okay, so here we are using our motor control and motor learning theories, which is helping for the development of movement patterns. Carryover, or what you can say is home exercise programs are to be encouraged. Okay, it's not like ek ghanta, 1 hour of treatment is done and now you can go and do as you like. No, always take home message is to be given to the parents so that at home also proper weight bearing and stretching exercises are being performed. You can always inculcate what you can say fun way by coloring the hand, pushing onto the wall. In this half kneeling, various positions are being given, which is encouraging the muscle activation and strengthening and control of the baby. Okay, and most of it you can see over here, the active participation from the baby is must to train for the functional activity. Okay, it should not be a passive procedure where you are just doing the movement and the baby is developing. No, baby should be actively involved whenever we are giving the treatment. We are using different kinds of wedges on which we are making the baby sit and give a reach out activity. So when we are giving the reach out activities, there are proper stretching of the muscles, activation of back extensors, which is helping the baby to move forward and backwards. So here, learning, stretching, activation, most of these things are to be incorporated. You, whenever treating only one component, we cannot concentrate. You have to create exercises or you have to give exercises where multiple amounts of things are given together. Play therapy, always inculcate play therapy where the baby is encouraged to do a task and the exercises are also being done. So here you can see that the baby with an AFO is being given hurdles so that the baby is learning to shift the weight onto the one leg and pick onto the other leg so that he can cross the hurdle. Okay, and when the peers are involved, when friends are involved, very nice results are seen with this. Okay, kinesio tapes are also being used nowadays to prevent any unwanted rotations in the lower limb, giving very nice results also. Hand splints and additional supportive devices are being advised with proper orthotist. Okay, usually physiotherapists and orthotists work in coordination to decide what kind of splint will be helpful for the baby. So a physiotherapist tells an orthotist that I want a splint such that the thumb should go into an abduction. So here are two examples of the splints which can be used if there is a cortical thumb of a baby, of a CP kid. The most important thing that is to be taught to a mother is how to lift and carry a baby. Okay, so lifting and carrying techniques when the baby is having a floppy neck or no neck control and the trunk is spastic. Okay, to inculcate the proper control from the truncal flexor muscle. Various carrying technique procedures are being given or advised or we are making the mothers hold the baby in that position. So this is helping with the stretching of some limbs. It is assisting the baby also to have a good look at the environment. On top of it, the muscles are also being activated. So these are some of the techniques which we are teaching the baby, we are teaching the mothers. Okay. On top of it, also when the mother is interacting or playing with the kids, like exploring the body parts, changing the dress, we are teaching them how to take the baby so that naturally there is a stretching while doing the activity. Okay. Do's and don'ts always is to be told about what positions are not to be taken up by the baby and what is to be encouraged. Okay, so W sitting usually causes tightness of adductors, internal rotators, and knee flexors. To combat these, we are encouraging cross-sitting position. If the baby is able to sit on a chair, that is more good than sitting cross-legged because the foot is going in plantar flexion. So when the baby is sitting on a chair, the leg should not be hanging. Okay, the foot should not be dropping down. It should be kept in 90-90 position so that the Achilles tendon doesn't get stretched out. Okay, playing with mother. So here you can see when the mother is playing with the kid, she is abducting the leg. So this is giving a nice stretch to the adductors, and the baby is very much busy with the mummy. Okay. So when the mother is coming in picture, the baby is playing with her. So this is helping to have midline activities. Okay. So this later on causes a good development of the pectorals, the frontal muscles also. Okay. Playful activities like picking up something and dropping it onto something encourages the truncal control. So the mother is being told where to hold, how to do the movement. On top of it, various positions with the use of instruments is to be advised, so that when the mother can't be there for 24/7 also. So if the mother is having some other work, we are using some instruments, some devices or assistive devices, which is helping with the stretching and lengthening of the muscles. So here in the picture itself, you can see the position itself is helping with the extension of the neck, holding onto the ball, throwing it. There is a stretching, proper stretching of lat dorsi, which is seen over here. Weight bearing on the upper limb is also seen. In side lying also, or in supine position, proper positioning of the limb is very important, and midline activities are to be encouraged. Most of our activities in our day-to-day work is being done in the midline. Okay, so for midline activation, the head position should be in the center, not rotated to one side. If it is rotated, it can give a chance to your primitive reflexes to come into picture, like APNR and SDNR. Adaptive devices gives a very nice input where the baby is to be supported and given a proper position for weight bearing. A proper cut in the table is helping him to have proper support on the elbows, and then he's able to carry on with his hand activities, not allowing any unwanted movements to be coming in pictures. Okay. Proper, whenever we are playing also with the baby, proper positioning is important. Here you can see that the foot is supported on the floor. It is not hanging. So this is helping it with proper alignment. Okay. And the hand is also splinted. So when the hand is splinted and it is coming onto the midline, the baby is able to look at the hand also, and he is able to play with this games also. Okay. These are some other modifications which we can see where the bolster is being used for causing abduction of the leg. You can use the strap for causing what you can say when the mother wants to carry on with activities. These instruments can be used for encouraging the home exercise schedule or program. Various orthotics and equipments are to be given. So this is to be decided with an orthotist. Okay. So what is our aim? Okay. So if we want a static foot orthosis or a dynamic foot orthosis, or posterior walker, or crutches, or a standing frame, or a T-cut table, it is to be decided by what we want from the baby. Okay. So if the baby is a small kid, we can't think about this at the very start itself. Later on, this will help us with the mobility. Okay. These are some more forms of devices which can be used. Don't think that it's not economical. So always there is a substitute. Okay. Always we have a substitute when we want to work with kids. We have to just use it. Okay. These are some more modified devices which are incorporated to cause proper weight bearing on the lower limbs, helping the lower limbs to grow nicely. Proper weight bearing is also being seen. Okay, and the baby is free to do activities with his hand. Okay. Now, physiotherapists are also working for post-surgical management of PP kids. Okay. So post-surgical management, like after tenotomy, osteotomy, the surgeries are being performed. So when the baby is in plaster, what all we are supposed to train, and once the plaster is being removed, what all exercises are to be incorporated is that what we are advising. We are going in a very slow manner, which is helping with the faster recovery also. after Botox injections also. Botox injection is effective only for 6 months, and the studies have already been proven it. But when Botox is being given with physiotherapy, it is being showing amazing results where the baby is getting a lot of functional mobility to move around, to achieve the independence. Okay. In the recent trends, aquatic therapy has shown beautiful results. Okay. The baby is enjoying the water. On top of it, the buoyancy is helping out to loosen up the muscles. Studies have also shown that EMG picture after taking an aquatic therapy is beautiful, causing reduction in spasticity also. Okay, and the pool and the water is always enjoyable by babies. Okay. Other recent trends are there like body weight support treadmill training, where a baby is made to walk on the treadmill repeatedly. So when we are doing a movement repeatedly, a small program is formed inside our brain which is helping us to do the movement. On top of it, there is robotics. Okay, robotics is also showing good thing. The final thing of what you say physiotherapy is to make the baby independent for to carry on his day-to-day activity. So walking is the most important activity. And for this, if we are making the baby functionally independent, that is the biggest achievement for us. Okay, there is hippotherapy also. In hippotherapy, the baby is being made to sit on a horse in various positions. Okay, and this is helping us to gain the normal movement pattern of dissociation. On top of it, there are virtual games, also biofeedback games, which is helping to gain the independence. Okay. Finally, at last, what we are requiring is a fit body with proper symmetry, okay, allowing the baby to move around independently, to gain the motor milestone and be the, what you call it as deformity free, or to have a proper day-to-day activities, and the baby is coming back in the society with flying colors. So this is what we are aiming for. In a nutshell, what I want to say is just physiotherapy is not working alone. Physiotherapy with other medical fraternity have to work hand in hand for the upliftment of a kid. And physiotherapy itself has whatever I have shown it. It is just like a bucket from an ocean. Okay, it is so huge. The topic is such huge that it cannot be completed in such a small time. But whatever I had tried to capture as much as things possible from physiotherapy perspective. Okay, so this is my favorite slide where this is what we are seeing, that no one will manufacture a lock without a key. Just what we are supposed to do is to find a proper key to unlock it. So we are supposed to solve the problems properly if we are working on it hand in hand all together. Thank you so much. Over to you, ma'am.
Yeah. Thank you, ma'am. Thank you for very, very nice session. With the help of pics, photos, and diagram, you explained the role of physiotherapy very nicely. So many participants are required for PPTs. So please share that. I will send on email of participants. Your PPT was so nice. So in chat box, so many participants. So many participants requested your PPT. Your communication skill is also very good.
Thank
so
you
nice.
So much, thank you.
Very nice.
Thank you.
Okay.
Questions are welcome now, ma'am.
Are there any questions you can put in chat box? Participants requested. Participant requested. If there are any query or questions, you can put in chat box. No questions. This is also not good. This is not good. Put some questions. There is one question, ma'am.
Yes.
After Botox injection, what exercise are given? Nice question.
Yes, actually, if we see Botox injections are being given in those muscles which are spastic. Okay, so it is commonly seen that anti-gravity muscles are the one which are spastic. So in those muscles, Botox injections are given. The opposite group of muscles are weakened up. So once you are giving Botox injection in the spastic group of muscles, as a physio, we concentrate on activating the opposite group of muscles, which is helping to further reduce the spasticity in that muscle. Okay. In the long run, what we see is after Botox injection, it becomes easy. If I take an example of gastrosoleus, if a Botox injection has been given in gastrosoleus muscles, we concentrate on mainly dorsiflexors. So when we concentrate on dorsiflexors repeatedly, the dorsiflexors gain its strength and the brain is registering the movement. So when the dorsiflexors are contracting repeatedly, the opposite group of muscles learn to relax it. Okay, so down the line, we see after Botox and physiotherapy, only Botox is not useful. Botox plus physiotherapy is showing results 5 months down the line when the effect of Botox is being reduced.
Next question is there. 1-year-old child with spastic CP has cortical thumb.
So for cortical thumb, what we mainly concentrate on is stretching onto the hand, okay, with proper weight bearing. Only stretching is not helpful, okay, stretching is temporary. To get a permanent result, you're supposed to give proper pressures also, and you're teaching the mothers and the parents by giving them advices like, for example, what I commonly tell them is, you take the cap of your pen, cover it with cloth, and keep it in between the thumb and the index finger and strap it. Okay, so there is a continuous stretch which is there on your adductors of your thumb, helping it to stretch. And this is used on top of it. Various orthotic devices are also there, which is being used to properly stretch the adductors of your thumb. Okay.
Next question, ma'am. How much results you find in CP at OPD level? Kindly share your experience.
At an OPD level, what I have seen is the results vary a lot. Okay. So usually few sets of exercises we concentrate and we just plan out first for the short-term goals. Okay. And the results are beautiful, but it's not only physiotherapy. Okay, it's physiotherapy and medical management when going together. Okay, then only we are seeing the results. In the long run, both and surgery, everything has to go hand in hand. Then only we are seeing the results. Results are slow. The energy expenditure is high, but we get a nice satisfaction once you see that a baby which has come to you crawling is now walking independently without anyone's assistance. So that target we are achieving. From person to person, it varies. And some give you faster results, some give some more time.
Next question. Role of Panchakarma instead of physiotherapy. Ma'am, you know Panchakarma. Ayurveda consultant can clear this point.
Yes, that is true.
Yeah. But I think Panchakarma and physiotherapy both simultaneously
That's true, ma'am.
good result. Will give the good result.
Hand in hand. Everything should be going hand in hand. Only you cannot rely on one specific point to treat a baby. Only one person cannot treat a baby. And it actually is a huge burden for the family to go to a multiple doctors and treat their babies. So a holistic approach is always good for the baby.
Yeah. Next question, ma'am. If baby want to do any activity, what to do, ma'am?
So it depends what is the activity. Okay. The thing is, first we are evaluating the baby. Okay. The evaluation of baby is not just for एक बार evaluate कर लिया बाद में evaluation की जरूरत नहीं. No. Okay. 3 months, 4 months down the line, you are supposed to re-evaluate the baby. See how much improvement is there. So when we are able to see that the target or what the baby is loving to do, depending on your examination only we are able to say that if it is possible or not. I'll give you a simple example. I had a kid who had TP, and he was not able to walk independently. But when I took that baby in water for aqua, the baby was within a week, the baby was walking so confidently in water. He was so happy. His mother was happy. And Botox injection was being planned for that baby. But with just 2 weeks session of aqua therapy, the baby didn't need any Botox. Later on, the carryover effect from aqua to floor was being seen, and the baby started walking independently. So depending on what you say, many factors are there which decide what exercises or what we can achieve for the baby. It's not a set protocol where we can see it. Day-to-day variations are there.
Next question is there. If baby is hypersensitivity and hyperactive, and half question they ask that, then what to do?
See, for hypersensitivity, hyperactivity, or ADHD, occupational therapists are the right person they can speak about. So there is a technique called as sensory integration, which concentrate on the sensory issues of the baby. Okay, so those are the right person who will be able to guide you properly on this question. But yes, we can desensitize. If a skin is hypersensitive, we can desensitize by giving various weight bearing techniques, which is helping for getting the movement control.
Next question, ma'am. For flaccid muscles, how to increase the tone?
For flaccid muscles, we are using the root technique or approach, where there's a technique which is called as fast brushing or quick stretches we are giving, which is helping for activation of the muscles at the level of muscle spindle. So repetition is helping with it. On top of it, positioning. That is also helping to, increase the tone in a hypotonic muscle.
On routine basis, how can we and which exercise we can advise the parent for child?
It is case to case. It is case to case. So most of the time, what we see is a spastic kids in our clinical perspective. So for them, we are advising to regularly carry on the stretching exercises. We are training the parents also. So it's not feasible for a parent to come every day to your treatment at the clinic. So what we are doing is we are training the parents how to stretch the muscles properly, seeing to it that we are not injuring the other ligaments, and then carry on the activities.
Next question. How much time CP patient takes to recover?
Actually, it's a lifelong procedure, to be very frank. Okay, regular follow-ups are required because the spasticity is a component which is treated, but it is not going away. Okay, we are giving weight-bearing exercises, activation of the muscles, but down the line, when the baby is growing, the baby is walking. After that also, if the baby is not exercising regularly, we are seeing that the baby is coming back with spastic or tight muscles, tight joints, contractures, deformities, which is causing surgeries in later life. So from start itself, we are seeing or educating the parents that till the growing age, it is compulsory at least to do regular exercises. After that, the baby learns on himself if he's continuing with the exercises properly, then only he's having the freedom of movement. Otherwise, the surgeries can come in picture at any given time if not done. If the baby is not doing the exercises.
Okay. Next is nice question, ma'am. What is the scientific basis for aquatic therapy?
Aquatic therapy is a newer concept and many researches are going on at present. One recent study was there in which it was being seen with an EMG evidence that after aquatic therapy, H reflex, which suggests that there is a UMN lesion, H reflex excitability is seen if there is a UMN lesion. And this study has shown that with aquatic therapy, there is reduction in the H reflex, allowing the baby to move freely. And results, what you say, research is still in, many researchers are going at present for aquatic therapy, and they are giving very nice results also.
Next question. Please share experience regarding how much results you found in OPD level.
At OPD level, what I would say is the problem is consistency. Okay. The thing is, consistency is a major problem because of the financial burden that is being encountered with the treatment of CP. So most of the time, what I have seen is the babies who are coming regularly, they are showing nice results, but once the results are being found, most of the parents discontinue the treatment. And after 2 or 3 years, they come that the baby was walking and now he has landed up with tightness, what to do. So suddenly the consistency is the main problem that we have encountered at OPD level.
Next question is the difference between CP and Erb's palsy.
Erb's palsy.
Erb's palsy, that is birth injury brachial.
So Erb's palsy is mainly because it's a brachial plexus injury, delivery complications. Okay, and CP is perinatal insight. Okay, CP is related with brain, and Erb's palsy is related with your brachial plexus from here. Okay, it's a very simple thing. It's UMN, it's LMN.
How does kinesiology tape reduce swelling?
Kinesio tape doesn't reduce swelling. The first thing what we are supposed to consider is kinesio tapes help with limiting unwanted movement. Okay, so when you are limiting the unwanted movement, the tissue that is being injured, that is protected, and that is helping with the reduction of swelling.
Next question. How to enhance the trunk activation without gym ball?
Gym ball. Okay. So it's not always that you're supposed to take the kid on the gym ball and then do the exercises. To activate a truncal control, your lap is also there. You can take the baby on your lap and you can give different, truncals, perturbations, and that will help with the activation of the muscles. On top of it, you can use a foamy pillow also on which you can make the baby sit and do the exercises. Okay, it's not always a gym ball has to be there. Okay, on a flat surface also, you can take the baby with your hands, you can give perturbations and activate the necessary muscles.
Many normal kids sit in W sitting. So what's wrong in them?
Actually, W sitting is not to be encouraged. If you remember, our ancestors also used to tell that Palsy mandi घालून बसायचं नाही. What our ancestors usually tell. If an elderly lady is there, she will also be telling you Palsy mandi घालून बसू नको. The thing is, because of W sitting, the legs are going in internal rotation. Okay, on top of it, the medial joint line is also getting strained properly. Later on, it is helping for no proper formations of your body alignment. Later on, when you are walking, the knee will be, having friction with the other knee. Okay, giving developmental abnormalities later on. So that's why W sitting is not to be encouraged. And normal kids also. Okay, always encourage cross sitting. That is the best thing to do.
Ma'am, lot of participants are requested again for your PPT. That is your appreciation. Congratulations.
Thank you, ma'am, so much. Thank you, ma'am.
How wedge position helps CP kid?
So wedges are being used. Okay, so there are different types of wedges, different heights of wedges are there which are to be used. Depending on what is your goal, that size of wedges is to be decided. So if you want to activate your neck muscles, not a large wedge, a small wedge is also helpful, which can be done with a roll. Okay, towel roll ka bhi karke we can activate the neck extensor. Okay, if you want to facilitate trunk extension, you have to use a larger wedge. Okay, if you want to stretch your muscles, then also you need a wedge. Okay, so height, height of the wedges, the slope of the wedges depends and vary. Okay, so you have to keep a combination of wedges at your clinic, which will help the baby.
What types of gait are seen in cerebral palsy patients?
There are many varieties of gait pattern you can see. Okay, the foremost and the most important is the scissoring pattern, which is seen because of your adductor spasticity. Okay, the other gait patterns that are being seen is entalgic gait, crouch gait, scissoring gait, knee hyperextension gait, ataxic gait. Okay, varieties of CPR, varieties of gait patterns are seen. Equinovarus gait, the most important because of your calf tightness. Equinovarus gait pattern is also being seen in CP. Okay, and in later stages, when there is a metatarsal break, okay, you are seeing that the baby is walking with a foot flat, but the knee is going in hyperextension. That is also not good. So, varieties of gait patterns. Then there is what you say is entalgic gait, or what you can say is Trendelenburg gait is seen if a baby is having hemiplegic CP. So one leg is normal, the other leg, the affected leg is small. So whenever the baby is walking, there is tilting of the pelvis. Okay, so that Trendelenburg gait is also being seen.
Again, this question, how kinesiotaping works in spastic CP?
Actually, kinesiotape is giving a temporary relief with the increased flow. So what kinesiotape is helping is, it is inhibiting the spastic muscle by activation of the antagonistic muscle. So when you are taping the antagonist muscle to activate, the spastic muscles relaxes on itself and it is showing results. But it's a long term, okay? It's not just for a day you are doing kinesiotaping and it is giving the result. Kinesiotaping has to be done for a longer duration to see actual results.
I think all questions we covered.
Thank you, ma'am. Thank you.
Thank you again very much for your informative session.
Yes.
Okay.
Thank you, ma'am, for giving me the opportunity to speak about the role of business.
So many participants requested for your PPT. My mail ID is in your post. So please send on my email ID. I will send it on group. Okay. Okay. Thank you very much, ma'am. Now, I would like to invite our MUHS observer of this webinar, Dr. Vipul Dixit, to speak few words. Just wait, sir. Just wait, sir.
First of all, thank to Dr. Avre sir, URD department, MUHS, Dr. Kalidas Sawan sir, Registrar, and Pro VC and VC of MUHS to giving me such an opportunity as a from the MUHS. And the main aim of MUHS is that in a single roof, under single roof, all the faculties of health science should come together, and they should run the programs which will helpful for the healthy society. So I'm congratulate to the team of the coordinate such a good webinar. The topic was much more important, and both speaker were also giving such a huge knowledge in a limited period, and sharing their practical experiences which will helpful to the all society. Thank you, everyone.
Thank you very much, sir. All the participants are requested to fill the feedback form, which is available now in chat box. Fill and submit that. Now our third session, that is valedictory session, will be start. And now I would like to invite Dr. Sukmini Dhurve ma'am for votes of thanks.
Thank you, ma'am. On the behalf of our institute and department, I want to express my profound gratitude to Dr. Pritam Pai ma'am and Dr. Snehal Rathi Lende ma'am. Both sessions were truly enlightening and informative for the listener. Once again, thank you, ma'am. I would like to thank MHS. They allowed to conduct this webinar. Also, I would like to thank our principal, Dr. Deshmukh sir, for his presence, and also he allowed to conduct this webinar. I would like to thank our academic in charge, Dr. Deshmukh ma'am, for her kind support and guidance for webinar. Also, I would thank to MHS webinar observer, Dr. Vipul Dikshit sir, for his kind support. And also, I would like to thank our beloved HOD, Dr. Ratna Parkhi ma'am, for her moral support and guidance for this webinar. Also, I would like to thank webinar committee. I am happy to express vote of thanks to our departmental staff members who have made this webinars grand success.
As a webinar coordinator, thank you all participants for such huge response. And now we are concluding the webinar. Please submit the feedback form which is available in chat box and submit that. Then and then only you will get the certificate in few days. Okay. Thank you again.